God. Happy Guru Purnima to all my respected teachers, friends and students. So today I am going to speak on angio embolization in liver disease for non-tumor patient. So basically I cover the all etiologies of the liver where angio embolization has a role. So basically angio embolization is the minimal invasive or non-surgical technique where we selectively occlude or close the vessel endoluminally. As in the surgery, we clip vessel from outside. In endovascular procedure, we occlude this vessel endoluminally from the inside of the artery. Various agents which use for occlusion include coil, PVA, glue and gel foam. Out of these, most commonly used is coils, and coils, PVA and glue are permanent embolic material which commonly used. However, sometimes gel foam may be used in some critical conditions. So, role of angio embolization liver is basically in the three conditions most commonly used in to stop bleeding in trauma patient. Second most common is the if bleeding occur because of some iatrogenic causes like in the biopsy, PTBT procedure or some surgical procedure. In some rare condition, angio embolization also has role in some medical causes like hepatic hemangioma, polycystic liver disease or some infective disease which causes injury to the arteries. So in hepatic trauma, angio embolization has major role because if we not control bleeding in liver trauma, it has mortality more than 50%. And liver trauma, or we can say that liver is the most commonly injured organ while blunt abdominal trauma. So in such patient, if patient is unstable at the time of presentation, usually surgery is the preferred choice. However, patient is in stable condition or it mildly unstable, that is it improve with the IV fluid, we should do CT, and if active association is seen on the CT, it is the first indication for the angio embolization. Sometimes even after surgery, if bleeding is present, then angio embolization has a role. According to some standard of intervention radiology guidelines, non-operative management should be treatment of choice in patient which has hemodynamically stable condition after liver trauma or persistent bleeding is seen even after surgery. And this guideline also recommended that we should always do selective embolization to prevent complication, and bleed to embolization time should be less because it is the key determinant of survival. This is the World General Society guideline. According to this guideline, patients of liver trauma are classified in 4 categories, and usually 3 categories are patients are stable condition, and these 3 categories patients are improved well with the help of angio embolization, and 4th category is usually improved with the surgery. And this guideline recommended that CT scan should with IV contrast should always be performed in patient where we consider non-operative management, and if on CT active association is seen, we should do angio embolization in this hemodynamically stable patient. This is a classical case. This patient underwent surgery after the liver trauma, and this is the hypoic structure is seen, which is because of the gauge pieces. However, even after surgery, the patient show hemoglobin drop. So we did CT, we show that this is the globular outpouch arising from the posterior branch of right hepatic artery. So this is the cause of the hemoglobin drop. So we selectively go in this artery and embolize using the coils. And this is the post-procedure CT. We show that coil in situ in this artery without any incision. So patient improved well. Literature also suggests that embolization has a role in severe hepatic trauma, as in this systemic review, which include 24 studies, and this systemic review results show that arterial embolization success rate is ranges from 80 to 97%. Literature also come up with the recent upgrade, that is angio embolization also has a role in hemodynamically unstable patient, as in this systemic review which include 12 studies, and Result of this studies show that high clinical success rate in hemodynamically unstable patient ranges from 93 to 99% and mortality is less than approx 1 to 7%. Second most indication for the angioembolization is iatrogenic cause of bleeding. Most common iatrogenic cause of bleeding is percutaneous liver biopsy. Even we know that this is the well stabilized mean for diagnosis of diffuse liver disease. It is usually safe. However, very less risk of bleeding is still present, especially if patient has a deranged coagulation profile. So we always recommend the plugging of biopsy tract if patient has deranged liver function at the time of biopsy or deranged coagulation profile. Even after plugging or all precaution, if bleeding is present after the biopsy, angio embolization is the life-saving procedure. Second most common procedure which do in the liver is the transjugular biopsy. It is more safer than the percutaneous liver biopsy. However, major complication in this transjugular liver biopsy is approximately 0.6% according to standard SIR guidelines, and mortality is less than 0.1%. And this mortality is directly correlated with the hemorrhage if it occur from the extracapsular liver puncture or perforation of the main hepatic artery. So if this condition arises in the transjugular liver biopsy, then also angioembolization is a life-saving procedure. As in this case, after transjugular liver biopsy, patient hemoglobin BP drop, so underwent CT which show active extravasation in the perihepatic space, and coronary section confirmed that disease arises from the injury of this posterior branch of right hepatic artery into the perihepatic space. So we go through the celiac axis in this right hepatic branch, posterior branch is selectively cannulated and embolized using the coils. And this post procedure show that now exclusion of this culprit artery, however preservation of blood supply of the whole of the liver. So usually complication is not arises after angioembolization. This is the pre-procedure and post-procedure. Compare CT which show that coil is through in this culprit artery as compared to previous baseline CT. The third most common cause of or iatrogenic cause of bleeding is the PTBT, and bleeding complication ranges in 2 to 3% of after the PTBT. This may be classified in three categories: perihepatic bleed because like hemothorax, hemoperitoneum, GI bleed in the form of hemophilia, or bleeding from the drain itself. If pericatheter bleed is present, we can manage by compression. However, if bleeding from the drain itself arises, it may be because of the arterial source or venous source. And if patient has arterial bleeding, usually patient show sign of hypotension. And in such scenario also, angioembolization is a very good role or life-saving. Sometime after surgical procedure, patient may show hypotension or bleeding. Here also has a angioembolization is a role. CT angiogram should be done prior to procedure to identify the culprit artery or anatomy of the artery. And if endovascular embolization not possible, we can choose percutaneous embolization to stop bleeding. Sometimes angioembolization has a role in arterioportal fistula. This is the condition where communication arises between any hepatic artery and portal vein. So hepatic artery is a high systemic pressure and portal vein is low systemic pressure. So this communication usually, if mature, it causes some symptoms. This may be because of the congenital condition or trauma. If these are the large, then require treatment. And according to literature, most common cause of arterioportal fistula is trauma, followed by iatrogenic cause. And symptomatic arterioportal fistula after biopsy or procedure is very rare. However, if patients show sign of decompensation after any procedure, we should offer patient a CT to rule out arterioportal fistula. It classified into three categories. Type 1, it is usually small and peripheral, and it usually causes very minimal physiological insult to the liver, and it usually arises by our iatrogenic procedure. They usually thrombose spontaneously, and in management of this type 1 usually recommended the follow-up scan. Type 2 is large central fistula which may arise mostly because of the trauma setting, and this patient usually presented with the hemoperitoneum or portal hypertension symptoms, and embolization is recommended choice. Type 3 is congenital fistula and the required multidisciplinary management program. Type 1 fistula usually asymptomatic, and other type 2 or type 3 fistula may have acute or delayed presentation. According to, if in acute presentation, mostly patient has a hemophilia. In delayed presentation, patient may present with the portal hypertension symptoms like bleeding, ascites, or sometimes congestive features like diarrhea. So for the initial screening, Doppler ultrasound is helpful. CT scan is more sensitive. In CT scan, early filling of portal vein during the arterial phase is a diagnostic marker, and hepatic angiography is gold standard for diagnosis as well as the treatment. So while doing the biopsy, we should recommend ultrasound with the color Doppler to prevent or decrease the chance of articular fistula. If this arises in the peripheral part of the liver and small in size, we can recommend follow-up. If it is large or patient have symptoms, endovascular management is the key role. Another important role of angioembolization is patient has some arterial injury because of some infective or inflammatory pathology, like in this case, pseudonesis arises from the segment 4 artery without any specific cause, which causes intermediate hemoperidium. So we super selectively cannulate this pseudonesis, which has bilobulated outline. So we use glue plus coil to embolize this. So art of this endovascular procedure is that we can super selectively embolize this culprit vessel only without any damaging the segment 2 or 3 branches. Our end point of the angioembolization is the complete occlusion of the vessels, afferent, efferent and pseudoaneurysm without any injury to the rest of the organ, which can be achieved in 90 to 100% according to literature if patient is in good condition. It is usually well tolerated because of the dual blood supply of the liver by the artery as well as portal vein. So if we sacrifice a small part of the artery, portal vein will take care. Rare complication may arise, especially gallbladder necrosis, if we sacrifice the cystic artery during the embolization. Third important indication for the angioembolization is for the management of symptomatic giant hemangioma. As we know that hepatic hemangioma is the most common benign neoplasm, ranges from 0.4 to 20%. If hemangioma is more than 5 cm, is usually symptomatic, and patient may present to us the pain, heaviness and dyspepsia. Surgical management is the primary treatment of choice. However, in recent literature show that surgery is usually associated with the morbidity in 13 to 26% of patients. So we can offer transarterial bleomycin lipidol embolization in such cases. In this technique, bleomycin acts on the endothelial cells, causing destruction of this endothelial cell, leading to microthrombi formation within the hemangioma and causing fibrosis of the hemangioma. This is a classical case where approx 20 cm large T2 hyperintense hemangioma seen in bilateral lobe of the liver. So this patient is not surgically fit because of the small residual liver. So we offer transarterial bleomycin embolization. We did multiple setting embolization in this patient, and we mix usually lipidol with the bleomycin to outline the hemangioma periphery. As in this case, after 3 procedures, lipidol is seen in the whole of the periphery of the all of the lesions. And if we compare this baseline CT MRI with the post-procedure CT, there is significant approx 80% decrease in the size of this hemangioma. So patient become asymptomatic, and even at the 7 years, patient will become completely asymptomatic. Second case where a young guy presented to us with the pain abdomen, large hemangioma approx 12 cm in posterior lobe of the right lobe, classical filling on the venous space suggestive of hemangioma. This is more vascular as compared to previous lesion. So lipidol go inside up to inside the hemangioma, and this is the only 3-month post-procedure CT which show that significant approx 60 to 70% decrease in size of the hemangioma without any incision. Till literature, no guideline exists about the role of angioembolization in hemangioma, However, papers or RCTs show that transarterial bleomycin embolization is safe and efficient to control symptoms and to prevent further growth. This is the meta-analysis which compare the lipidol-based technique versus the PVA technique, which is used. PVA technique is previously used in the old time. So this review showed that lipidol-based treatment shows significant effect in reducing hemangioma size as compared to PVA-based. So if do angioembolization for the hemangioma, we should always do lipidol-based angioembolization. Then only it show good results. In our center, we did hemangioma treatment in 16 patients. In 16 patients, 20 lesions we treated, and we found that if lesion is less than 11 centimeter, it show approximately 50% decrease in size at 3 to 6 months, and if lesion is more than 11 centimeter, it show more reduction in size as compared to less than 11 centimeter size. So I conclude my talk by saying that IR treatment is life-saving, especially in trauma and iatrogenic bleeding, where surgery is usually not possible. Bleed to embolization time is one of the key determinant to survival, because we stop the bleeding but we are not able to resuscitate heart or other things. Transarterial bleomycin lipidol embolization is safe and should advise in giant hemangioma. We should not offer PVA based technique for embolization, because this lipidol based embolization significantly decrease the size of hemangioma and decrease the symptom related to the hemangioma.